All right. Hello, everybody. Welcome to the UVA Medical Center Hour. My name is Justin Mutter. I'm director of the Medical Center Hour here at UVA. This is a program of our Center for Health, Humanities, and Ethics at UVA. If you've never been with us before, delighted to welcome you, those who are here in person, as well as those of our friends who are on Zoom. Just really quickly, a few protocol things about how this runs, because it is a hybrid event. Today is for both our UVA community and our broader community to engage in these key issues of health and society. And when it comes time for questions from our attendees, we'll have a microphone for those of you who are here in the live audience, and then we'll also have the ability for those on the Zoom webinar to ask questions. So feel free to put your questions into the Q&A tab in Zoom, and we will submit those. I will moderate the discussion during the Q&A. Continuing education credit is available for your participation in today's event. I just need to show a few quick slides for those on Zoom. They've been circulating, and then here in the background as well. For continuing education purposes, we're delighted to be able to offer credit. So really quickly, Dr. Matri will talk about disclosures, but the important thing is there's a new process for people to claim credit. That is this online platform. There's a way to do it that is texting. There's a way to do it online where you put in the code. The most important thing is the code 24642. And you can do that within a 7-day window of having participated in the event for it to go through and for your credit to be claimed. There's some handouts for those of you in the back if you want to snap a photo of that in order to remember to claim your credit. But now to the big event, and we're so delighted to have Dr. Matri back with us. Burnout is sadly now as commonplace in healthcare as it is challenging to resolve. Many, if not most of us in the field of healthcare, will experience it at some point in our careers. Our distinguished speaker for today, Dr. Sneha Matri, has dared to ask, what can narrative medicine teach us about navigating the landscape of burnout? Dr. Matri is a longtime friend of UVA, having completed both her undergraduate education and her residency training in neurology here in Charlottesville. She's now the director of the program in medical humanities at Duke University's Trent Center for Bioethics, Humanities, and the History of Medicine. She's also an associate professor of neurology there and a movement disorders specialist working clinically. Her career is full of many accolades, most recently as the recipient of a Josiah Macy Foundation grant as a faculty scholar, and her presentation today stems in part from her innovative work associated with that grant. Please join me in welcoming Dr. Matri to our Medical Center Hour stage.
Thank you, Justin, and thank you all for being here. I am so excited to be able to share with you some of the work that we've been doing at Duke and elsewhere around this really important topic. I'm going to be talking about thinking beyond burnout and how we can use interprofessional care, narrative medicine, and novel ways of knowing to sort of change the culture at our health system at Duke, and hopefully we'll have some lessons for UVA and for other health systems around the country. These are my disclosures. The most relevant ones here are the ones at the bottom. A lot of the work that I'm going to be sharing with you is supported by the Purpose Project, the Trent Foundation, and the Duke Office for Faculty Advancement, and most recently, the Josiah Macy Foundation Award that I'm so grateful to have received. All right. But more important than the disclosures to me are the dedications. These are the people who I think have really shaped my career both when I was an undergraduate here, Jennifer Chen, my thesis advisor, David Morris, who taught a course in literature and medicine that I took as a third-year undergrad, and really sort of opened me to this idea that literature and medicine and narrative medicine was a thing that could exist. Lynn Harrison, who's always been a friend and champion, and Danny Becker, former director of the center here at Duke. Andy Sutherland was my program director as a resident, and was always a champion of this kind of work, and especially Ted Burns, in memory of him. He was the person who convinced me to come back to UVA as a resident, and I think we all miss him greatly. But this is where I work now. This is the view of Duke Hospital, the Duke Medical Pavilion, the Cancer Center, from the roof of the main patient parking deck. And it's a beautiful view, right? Like this is the glossy thing that they put on the newsletters that they send to, potential donors and others. This gorgeous building, all lit up. Even the street lamps have little halos around them. The lawn is manicured. It looks like it's an amazing place to work and an amazing place to receive care. But what's going on inside this hospital? And this is what's going on inside the hospital, and I'm sure is going on inside the hospital here at UVA right now as we speak. Chaos and challenges of taking care of very sick patients with sort of less resources sometimes than we would like, both in the inpatient setting, the outpatient setting, and in part because of that, this increasing reliance on what are sometimes called quick fixes in medicine. Another pill, another metric, another quick thing that you can do to get the patient out the door, get the patient stabilized, and move on to the next patient, because there's always more people waiting to be seen. And that is, I think, one of the things that leads to what we sometimes call burnout in the medical profession. And I'm going to kind of argue here that burnout may not be quite the right term for that, but burnout is really this metaphor that relies on the idea of a gradual decrease in our level of well-being and our ability to care for other people, this matchstick kind of burning out, if you will. It was first defined in the sort of late 70s, early 80s by Christina Maslach as consisting of these three components: emotional exhaustion, cynicism, and reduced personal or professional efficacy or professional accomplishment. This is kind of the classic triad of burnout that gets measured in things like the Maslach Burnout Inventory, the Copenhagen Burnout Index, and other scales. More recently, folks like Tate Shannonfelt and others have tried to look more specifically at what are the real drivers of burnout and what pushes people towards burnout or towards engagement in their work. And this is, one conceptual model of how burnout and engagement intersect with daily work. You can see that part of it is around workload and job demands, control and flexibility, work-life integration, and so on. I really, for the purposes of this talk, will be focusing on what Shannonfelt puts at the middle of his slide, the concept of meaning in the work that we do, and how can we increase people's sense of meaning and purpose in what they do. Because I think this is a problem that, certainly predates the pandemic, but got a lot worse during the pandemic. I'll show you some data on that in a moment, but this is a commentary by Danielle Offrey. Some of you may be familiar with her work. She runs the Bellevue Literary Review that was published in Academic Medicine in November of 2019. And she wrote, in this rather scathing article about the current state of healthcare, or the 2019 state of healthcare, I guess I should say. The despair that many of us feel is more than just burnout. It is a betrayal of trust, the trust we gave to our own profession. And as I mentioned, this started, well before the pandemic, and I think really accelerated in that context. Some work that one of my colleagues at Duke, Jane Gagliardi, who's the Associate Dean of Wellbeing at Duke, has done, looking at the levels of distress, anxiety, depression, and shame in medical students. This was a look at really, she surveyed all the years of med school. About half of the respondents were first-year medical students in this survey, and found that, about 40% of med students have moderate or concerning levels of anxiety at the start of med school. About half have significant symptoms of depression within the first year of med school. And interestingly, Dr. Gagliardi also looked at axes of marginalization among the medical students, looking at race, gender, and sexual orientation. And, perhaps unsurprisingly, found that as the levels or axes of marginalization increased, anxiety and depression also increased. So these are students who are, coming in sort of perhaps at the borderline or needing support in med school and are not finding it because they're feeling marginalized on various levels. So this starts early and this persists. This is some work that me and some of my colleagues at the Trent Center did, surveying with focus groups, faculty, residents, and administrators around the terminology of burnout. We asked people, what comes to mind when you hear the word burnout? And the word cloud on the left there illustrates that the most common word that was used to describe burnout for these groups, again, faculty, house staff, and administrators across the board, was divide. People feel divided, people feel isolated, people feel siloed. And you can see on the right some longer quotes of what people, when I asked them to describe what burnout felt like to them, people were not describing necessarily, I have to click a million boxes in Epic, although that can certainly be a source of burnout. That was not what people were describing as the reason why they were struggling in their work. If you scan the QR code, you'll get the full article that has the more extensive quotes from our participants. But the one that I want to focus on here is the last one, moral injury. Because I think this is a different way of thinking about the problem that offers us some new solutions. So we used some of that work to begin to develop the moral injury symptom scale for health professionals. This was developed initially in the veteran population, because veterans often, when they are sort of confronted with the challenges of being in war and then have to reintegrate into civilian life, often have real struggles with that. So the Veterans Administration and others developed this moral injury symptom scale for veterans. We adapted it for health professionals, really focusing on concepts of shame, guilt, meaninglessness, isolation, that word divide again, remorse over having violated one's core moral beliefs, a sense of betrayal, and a sense of divided self. Who I am at work is not who I am inside or who I am at home. And this sort of idea of boundaries and how that can hurt us as much as it can help us. And so this is the scale itself. You can see that it focuses on those kind of core concepts of betrayal and guilt and shame and meaningfulness or meaninglessness, forgiveness and failure. We also asked people if their moral injury symptoms were leading to functional impairment at work or at home in relationships with others. And we validated the scale actually right before the pandemic, and then COVID happened. And it really shifted the way that we were practicing medicine really abruptly. I want you to sort of think back to the spring of 2020 and how chaotic and how terrifying in so many ways that time was. So during the initial sort of onslaught of COVID, we sent out our newly validated moral injury symptom scale in a global online survey that we conducted in 2 phases, one in the spring of 2020 and then again 6 months later. Interestingly, when we were first designing this study, we thought that the 6-month mark, things would be back to normal and we would be able to do like a look back and see how this had changed. Little did we know what we were in for, right? But in any case, about 1,800 people took the survey. You can see the breakdown there of different professions. The vast majority had either personal or professional experience with COVID. Certainly by the fall survey, almost everybody had either had COVID themselves or was working on a COVID unit. And what we found was that, in April of 2020, moral injury levels just kind of follow this pretty clear bell-shaped curve. This was quite similar to pre-pandemic levels of moral injury in terms of the mean and standard deviation. 6 months later, there was a statistically significant increase in moral injury among respondents. And perhaps most concerningly, the level of functional impairment had almost doubled in 6 months. Like this is, this was a really concerning finding. We also looked at those same measures of burnout. We administered the Maslach burnout inventory simultaneously and looked at moral injury in comparison to emotional exhaustion, depersonalization, and professional accomplishment, which, if you recall, are the 3 kind of primary focuses of the burnout scale. And we found that emotional exhaustion actually did not change over the course of those 6 months. Depersonalization didn't significantly change. There was a trend towards increased depersonalization, but really not, that much of an objective change. And professional accomplishment actually increased over the 6 months of the COVID pandemic. So people were feeling more accomplished in their work, more engaged in their work in some ways, and yet their moral injury levels were rising. So I want to make the case here that moral injury is a really distinct aspect of healthcare worker experience that isn't measured by some of these other scales that look more specifically at, quote, burnout. So, all right, what does this tell us about how we can make a change? How can we rediscover a sense of meaning and purpose in our work? And why do I think narrative medicine might be the answer? So narrative medicine, for those of you who are not familiar with it, is this sort of reconfiguration of an approach to patient care and an approach to healthcare in general that focuses our attention on the lived experience of patients and practitioners. Rita Sharon, who's sort of the grandmother of and the founder of narrative medicine, at least in its modern state, defines it in these 3 ways. There's the attention to the story itself, both the history that the patient or their family is giving you, as well as the nonverbal story that is being told by the body, the embodied storytelling. There's the representation of that story in a medical note or in documentation or an illness schema that makes sense of the story or attempts to make sense of the story. And then lastly, there's this move towards affiliation, the affective move towards caring for another person that is often at the core of what we do as healthcare workers. And so Rita defined this in this article from it's 23 years old now, and I'm not going to read the whole abstract out to you, but I encourage anyone who's interested in this area to look at her work, her early work in this space. But in the article, she outlines these 4 central narrative situations in medicine and in healthcare: physician and patient, physician and self, physician and colleagues, and physician and society. And I'll just put in a little sort of note here that, Rita is a physician. She's a primary care doctor. I'm a neurologist. And a lot of the work, the early work in narrative medicine did come out of medicine and MDs. I would now, if I were writing something like this now, I would probably say clinician rather than physician, because I think a lot of this work is improved by the use of interprofessional and interdisciplinary care. But I just want to acknowledge that the early stuff is all kind of physician oriented. So what do we mean by clinician and patient? So this is, again, the attention, the really deep awareness of what a patient's illness story may be. Oh, I'm missing a slide. So the work of Arthur Frank, for instance, who was a sociologist who interviewed a number of patients with cancer and sort of mapped out different illness schema, breaks out those illnesses into, people who have a restitution narrative, a story in which they are well, they become sick, they get treatment, and they are restored back to how they were, who they were before the illness. And Frank talks a lot about the drive for the restitution narrative in healthcare and in medicine. But for many of our patients, restitution is perhaps not the way that people really experience their illness on a day-to-day basis. I'm a Parkinson's specialist, and for many of my patients, restitution or being sort of back to baseline, as we say sometimes in medicine, is a really tricky proposition. And what patients actually experience, if you ask them and if you talk to them and you give them space to talk about this, is what Frank describes as a chaos narrative. So, this shifting uncertainty, there are good days and bad days. Sometimes within a given day, there might be good moments and bad moments. And you never know what's coming next. And that unpredictability, that chaos can be a really distressing place to live in, both for patients and for those of us who are trying to take care of people, because it's often hard to make sense of a chaos story. And what narrative medicine allows us to do is help move from the chaos story or the chaos narrative into what Frank calls a quest narrative. So moving into this idea that, you are well, you become ill, and, perhaps you're not restored back to your physical self before the illness, but through the process of your illness, you undergo an emotional or for some people, spiritual transition or transformation, and become a different person than who you were before. The example that I always give here is Michael J. Fox, who was diagnosed with Parkinson's disease at age 29. And he writes in his memoirs about how he went to a very dark place for a time and then worked through that and has now become one of the greatest advocates for Parkinson's research. And this desire to make living better for people with Parkinson's disease. And I think you could say that about almost any chronic illness, that, there are folks who, through the process of that illness, become advocates, become stronger people, and really transformational, both for themselves and their families, but also for society at large. I think narrative medicine also has a role to play for ourselves directly as clinicians. So many people will use narrative practice as a way to step back from daily clinical work to sort of review your experience, reassess what just happened. Clinical debriefs, for instance, can fill this role if done well. I think there's also, I think of this as like the self-care angle of narrative medicine. But I think there's also what I would call an other care angle to narrative medicine, which is trying to think about the perspective of whose story is it and whose story is it to tell? And asking that question can help you really challenge normative frameworks. It can challenge the status quo, and it can really empower patients or other marginalized voices to take space again. Especially in a world where, things start to get very regimented as they can in healthcare or in medicine. Narrative medicine allows us to connect with our colleagues. This is a picture from Narrative Medicine Mondays, which we run on a monthly basis at Duke, bringing together folks from the undergrad side, from the medical side, patients, everybody into this room and this sort of open table, if you will, where we can talk about illness challenges together. Some of these are run by undergrads, some of them are run by med students, some of them are run by faculty. It's a very sort of anti-hierarchical space by intention. And then lastly, narrative medicine gives us an opportunity to communicate with society at large. As healthcare workers, I think many people outside of healthcare don't necessarily know what we do every day. And that can be really challenging, even just in communicating with family and friends who are not in healthcare, let alone greater society. So this is an article about abolition medicine from one of my former professors at the Columbia Narrative Medicine program, talking about militarized metaphors in healthcare and how they create sort of us versus them narratives that can be quite harmful to patients and to clinicians. And this is an op-ed that was published in the New York Times by a third-year medical student about gun violence and the impact of gun violence on folks who work in the trauma bay. I've talked about moral injury as an alternative framework to burnout. I've talked about how narrative medicine can address some of those concerns of moral injury. And now I want to spend the rest of the time talking about what we've tried to do at Duke to try and develop an integrated framework, really addressing some of these concerns from the ground up, if you will. So we actually start with pre-meds or pre-health students. This is spearheaded by my friend and colleague, Dr. Warren Kinghorn, who's a psychiatrist with a co-appointment in the Divinity School at Duke. And he's created this program called ReMed, or Reimagine Medicine, which is a week-long intensive in mid to late May, just after classes end, for pre-health juniors and seniors at Duke. Most of them are pre-med, although many of them end up going into other careers, as you'll see, related to healthcare, because ReMed is quite unique. It's an all-day program where in the morning they have different sort of topic sessions, lunch, and a shadowing rotation with a non-physician provider. So physical therapy, social work, occupational therapy, and so on. You can see in the graph on the right the sort of range of different topics that they cover in the morning. So really very focused on arts and healthcare, embodiment, physicality, expressive writing, and so on. And this runs for a week in May and is followed by an evening short course during the fall semester and near peer mentorship from medical students and other health professional students throughout the summer and extending into the fall. These are just some quotes from some of the students who took ReMed, not this past summer, but the year before, that this was transformative for them, that their purpose was shifting and they were understanding their place in healthcare better. And this last student who was trying to focus on strategy toward long-term sustainability, how are they going to carry these lessons forward with them into their health professions, education, and beyond. And that's where the rest of what I do sort of comes in. I've been very fortunate over the last 4 years at Duke to have built the Armstrong Humanities Scholars Program. This has been a long time coming, but it's really built around the legacy of Dr. Brenda Armstrong, who was longtime Dean of Admissions at Duke and was an amazing physician activist who was really focused on making life better for those who come after, was sort of her motto in life. And the Armstrong Scholars Program is 4 components, sort of mapping onto the 4 years of med school. I should say here that Duke has a very interesting medical curriculum where the first year is the only preclinical year. The second year is the clinical rotations. The third year is a scholarly year. And then the fourth year is a sort of creative capstone. So we start with Moral Movements in Medicine, which is an interprofessional elective designed for first-year medical students and other preclinical phase learners in nursing, PT, OT, and our PA programs. I have an amazing faculty team that helps me to teach this from across the health sciences campus. It works out to about 20 hours of coursework over the academic year. You can see this year's discussion sections. Each student is in one of these discussion sections that meets about once a month. And then there are some additional, what we call humanities options or course elective activities, which allow students to intersect and integrate across the different discussion sections. So for instance, walks through social history will take students to different neighborhoods in and around Durham, led by one of our faculty members and a community leader who is really the one telling the story. The faculty member is there to take attendance for the students, quite frankly. It's the community member who's telling the story of that community and how the built environment impacts health and access to healthcare. We have book discussions, service learning, movie nights, and so on. Our student enrollment has grown almost year after year, particularly among the med students. You can see that we started in the fall of 2020 with a pilot year all on Zoom, 12 med students, 15 PA, 5 nursing, and 7 PT students. And then we've grown certainly in the med school every year since then. This year, there are 48 med students enrolled. That's about a little over a third of the med school class at Duke. And we've got enrollments you can see from the other programs as well. In the second year med school at Duke, which again is the clinical year, we have a series of reflective writing workshops about once a month, which focus on clinical debrief and professional identity formations. This is led by a really great team, Dr. J.D. Ike, Dr. Harris Solomon, who's an anthropologist, who's interested in the ethnography of what happens to people over the course of their clinical year and their clinical rotations, how the students themselves are changing. And then this past year, we had a psych resident as well, Dr. Yeki Song, who served as sort of a bridge for many of the students. Sometimes they listen to the residents more than they will listen to faculty, and they can see the impact that this has in their residency programs. In the third year, we have electives, which are open to the entire class, not just the Armstrong Scholars, but specifically for the Armstrong Scholars. We have a series of community conversations, which are quarterly gatherings of our students, faculty mentors, and either an internal or outside speaker who exemplifies socially responsible or imaginative healthcare practice. These are just a few of our recent speakers. The ones you may know include Anna DeForest, who I understand was here recently for Medical Center Hour, and Dr. Perry Klass, who's a pediatrician, who is speaking about sort of the changes in the understanding of childhood and child health over the 19th and early 20th centuries. We also have an annual ethics night, which again is open to the entire health system, but Armstrong Scholars get priority registration for ethics night, and we often will give them an opportunity to, like for instance, last year, one of our speakers at ethics night was an Armstrong Scholar, speaking about the impact of she had done the fellowship at Auschwitz for the study of professional ethics, and talking about, how a horror like Auschwitz could have happened, not just with the complicity of doctors and nurses and other healthcare providers. And what does that mean for us now as we're trying to take care of people and populations? And then our sort of capstone, if you will, or our senior seminar for the Armstrong Scholars is called Humanities for Health Justice. It runs every year in February as a full-time 4-week elective, really a graduate level course in narrative medicine, advocacy, and ethics. as well as clinical preceptorships by both MD and interprofessional faculty members, and mentorship opportunities with, for instance, the students who are doing re-med or some of our other student-focused programs. This is our planned assessments. So we're doing qualitative analysis and programmatic feedback while students are in the program, some post-program assessments as well. And then I intend to do long-term check-ins with these students at the 5-year mark. So, you know, as they're finishing residency, transitioning perhaps into their careers, and then at the 10-year mark, when they're kind of a little bit more established in their careers, how did this program affect your decision-making and your care, your patient care over the years? Interestingly, the strength of the Armstrong Scholars Program has also allowed us to grow within the MD program itself. As I showed, you know, MD enrollment to Moral Movements in Medicine, our first-year course, has quadrupled. Applications to the Armstrong Scholars Program now exceed the available funding that I have to take scholars, which is a good problem to have, but it's also very, very hard to turn people away from a program like this. And because of that, because we were getting so much buy-in from the students, we were able to form a health humanities task force within the School of Medicine Curriculum Committee, which led to, among other things, the development of a dedicated half-day of narrative medicine and humanities during the clinical year ambulatory block. Our students now have a 16-week block of ambulatory rotation, and Wednesday morning is sort of the didactic morning. And so we have a dedicated half day for all medical students, not just the Armstrong Scholars, to get a little taste of this during that ambulatory block. And it's also, I think, really revitalized the med student humanities research track and the electives sequence that I alluded to. And this is, I think, you know, the most important slide of this whole presentation. I got an email about a month ago from PGY1 who had been an Armstrong Scholar. She's now an emergency medicine resident at the University of Chicago. And this was just unsolicited, out of the blue. She said, you know, I'm on trauma surgery. It's the worst rotation of my entire residency. And she keeps thinking back to the Armstrong Scholars Program and how it helped her not slip into horrible habits under the constraints of a dysfunctional system. I mean, I can't ask for a better testimonial than that in terms of the impact that this is having on people who are, you know, engaged and interested and excited by this work, but are trying not to get beaten down by the system of education and training that we've sort of created for medicine in this country. So what's next? I have so many ideas, and I hope we'll have a chance to talk about some of them here. One thing that I'm currently in the process of doing is expanding the Armstrong Scholars Program into the interprofessional space with some support from the Josiah Macy Foundation. Because the School of Medicine will not, unfortunately, let non-med students register for med school electives, we are creating a new elective, an interprofessional course called Humanizing Healthcare, Bridging Stories and Practice, which is a weekly seminar course for clinical phase learners in the non-MD programs at Duke. It's a semester-long course to try and fit within the constraints of their own, you know, professional programs. But it'll essentially recap a lot of what we do that has been so successful with the Armstrong Scholars. There'll be reflective writing workshops, ethics seminars, a section called Change Makers, which is focused on advocacy and healthcare history with an emphasis on structural change. And then the walks through social history, which have been one of the most popular part of the Armstrong Scholars Program. This spring, I'm really excited because we're going to be participating in something called Global Classrooms, which I don't know if you've done any of this here at UVA. I'd be interested if you have to hear people's feedback. But it's essentially a partnership between us, the University of North Carolina at Chapel Hill down the road, and the University of Exeter in England. And it's going to be an online virtual learning space. This is me in the learning space on a Saturday morning. You can see, you know, there's students leaving notes about what they're seeing and what they're experiencing in the real world into this virtual space. So, TBD here, I'm very excited and very interested to see how this kind of virtual and communal space will sort of function over the course of the spring semester. And then my sort of last big idea that I want to leave us with is, this very nascent and developing idea in my mind for what I'm tentatively calling the Southeast Narrative Medicine Network. In part because I think, there are so many academic medical centers across our region that are all struggling with very similar things. How do we engage students in health humanities and ethics across the spectrum, from pre-health students and undergrads, graduate students, medical students? How do we get people talking to each other, PT, OT, everybody, right? And we're simultaneously grappling with the tension between often our academic center and the town that we live in. I haven't even had a chance to get into this, but the relationship between Duke and Durham is very fraught. The relationship between UVA and Charlottesville and Albemarle is very fraught. I did some of my training at Penn. Like, this is the case, I think, at every academic medical center. And is there a way that we can use narrative medicine to break outside the sort of the ivory tower, if you will, and reach into the community and engage better with community leaders in this way? So that's all I have in terms of prepared slide. I'm eager for a conversation, either here now, later this afternoon, or online. And you can always reach me at these locations.
Thanks so much. And please, if you're in the audience, just raise your hand if you have a question, and we'll bring a microphone to you. If you're on Zoom, feel free to put it in the Q&A tab where I will see it and pass it along to Dr. Matri.
Thank you. I guess I was very intrigued by this alternative to burnout that you're calling moral injury, and kind of thinking about the components of moral injury. I'm assuming like resiliency, and like that has something to do with preventing moral injury, especially in students. And I was wondering if you could elaborate on like what some of the practical components of that might be, like especially when you're trying to foster resiliency through this like fellowship, like the Armstrong Scholars that you've been doing. Like, what does that look like for undergrads, maybe for medical students? And like, how do you think the curriculum helps foster resiliency?
That's a great question. Thank you for asking that. So yes, I think resilience or resiliency is an excellent way to address some of the things that drive people into moral injury or moral distress. I think a big part of resilience, though, is that you have to think about it not even so much as an individual practice, but as a communal practice. So one of the reasons I think the Armstrong Scholars Program has been such a success is it's created a community of scholars and a faculty, honestly, who are engaged with each other on an ongoing basis. So we have these monthly sort of clinical debrief sessions, and part of it is about sort of individually, if you will, writing and thinking about and reassessing, a clinical scenario that didn't go so well, or a conversation that you wished you'd had with a patient or a family, or something like that. But it's also about being in a space together with other people who are also going through the same thing, and realizing, validating your experience, realizing that you're not alone in what you are doing and experiencing. I will say the other thing, just on a very practical level, what I started doing, I think as a neurology resident, maybe it was as a med student, I carry a little notebook with me in my, neurologist's bag. And after each patient, I write something down about that person, something that doesn't go in their clinical chart, but is important for me to remember. Sometimes it's not even, I need to remember this about this specific person, but it's something that reminds me about why I'm doing the work that I'm doing. And this is something that takes literally 10 seconds, 20 seconds to do between patients. I call it microdosing narrative medicine because it's these tiny little, but this regular habit, this regular practice was sustaining to me in residency, and it's been sustaining to me beyond. And so I encourage the students to do that as well, just to, whether it's, I'm old school, and so I'll do it in a notebook. Some people like using like the notes app on their phone or something. Obviously, you want to be careful that you don't want to put any PHI or anything identifiable in there, but it's just really tiny moments of connection. What Faith Fitzgerald in her essay on curiosity, which I also highly recommend to anybody, Faith Fitzgerald calls it these small bright stones, these little moments of connection with another person that I think can be really sustaining against, the challenges of taking care of sick people in a system that is not always designed to help them.
Oh, thank you. Thank you so much for being here. I was really interested in the scale, the questionnaire examples that you were showing. I'm sorry, I'm not using the right word. The questions around the extent of moral injury. I don't spend my days in clinical facilities, but most of my best friends are physicians. So I hear a lot about their days. And what struck me about that scale was that it seemed to be, to a certain extent, measuring the difference between what I thought my life would be like as a doctor and what my life is as a doctor. And if I am barking up the right tree in that regard, is there any part of your work or your colleagues' conversations that is about a different way of introducing students to what their life will actually be like as a doctor? And that our job is not, quote, saving people's lives. But if I imagine that my job was listening very deeply and sitting in the trenches with people as they experience the natural pain of life, then I might feel very differently about how effective I was. If I think that my job is taking away all of their pain, then yes, every day will feel mostly terrible. So anything in there that has come up?
Yeah, thank you for asking that. I think you're absolutely right that we need to do a better job of sort of letting people know what healthcare is like. I think in some ways it's a little challenging because the system itself keeps shifting and changing. Like when I was an undergrad here, I was, shadowing people in the outpatient setting. I volunteered at the hospital. I sort of did all the things that you're supposed to do to get into med school. And and then med school changed, right? And then COVID happened and med school changed again. And then, it's always changing. And so I think one of the things that, for instance, Reimagine Medicine is trying to address is exactly that, is getting students, juniors and seniors in college, third and fourth years, sorry, to work with professionals who are sometimes not in medicine, usually not in medicine, but professionals who are specifically sort of selected to be preceptors because they do exactly that. They sit with people when nobody else will. And getting the students to see that and to understand that that is, what practice should be is, I hope, transformative for them as they get into, med school, nursing school, PT school, and beyond. I think one of the big challenges, which is a more structural thing, is that even when you want to practice that way, how do you do it in a world that is focused on see more patients in less time? And that's a bigger conversation with administrators, I think, to try to demonstrate the value of this. But, you know, I think the moral injury and burnout language to some extent has been kind of taken up in the popular press and the popular media a little bit. So I think administrators are perhaps a little bit more open to that now than certainly they were 5 or 10 years ago when I kind of started in narrative medicine. And it was really kind of seen as this other outside thing. I think at Duke, at least, we've been fortunate that our curriculum committee and others have been able to see the value in this for the most part.
Hi, thanks for speaking today. So I am of like the group that thinks that sometimes things can't be put into words. Sometimes it can't be spoken. Sometimes it can't be written down. Do you guys promote any other mediums of narrative medicine through your curriculum?
Very much. So I come from a literature background, so that's why everything I do is kind of words oriented. But one of my colleagues, Dr. Ike, was an art historian before he went to med school. He's a hospitalist now, but he runs our kind of second year clinical debrief curriculum. And most of what he does is visual, either, you know, prints or, you know, PowerPoint type visual stuff. We also have a museum on campus that we take the students to usually twice a year at the beginning, focusing on sort of observation skills, and then reflecting, you know, by the end of the year, how their sense of observation has changed over the course of, you know, second year, their clinical rotations, because often when at the beginning of the year, students are actually a lot more open and they see more. And then over the course of their clinical rotations, they've learned to see in a particular way. And pointing that out to them, you know, they're sometimes horrified at themselves, but it's a real wake up call. You know, it's a real kind of acknowledgement that you have changed over the course of this year. And in some ways you're seeing things that you didn't notice before, but you're also missing other things that you would have seen, you know, 6 months ago or 8 months ago. So that I think is a really, really powerful example of using other media. One of my colleagues is also very into like film clips and using, you know, the language of the camera as it moves through space as a way of storytelling. So yeah, you can use all different kinds of media for this.
So I want to ask a follow-up question, kind of at the 30,000-foot view, if that's okay. I mean, just first of all, thank you again. Amazing work that the team is doing at Duke, and really appreciate you sharing that with us. I think one thing that comes to mind in discussions about narrative medicine and its role in our milieu in healthcare is how do we avoid what some people might call the instrumentalization of narrative medicine? So, you know, and we see this in the wellness discussions and where I think one of the quotes there said, I don't want to just do yoga on your slides. But in some ways, there's some discussions, and I've heard narrative medicine theorists say this as well, that there's a fear that sort of narrative medicine becomes this tool that we use outside of the real world of medicine, and becomes, you know, an instrument for the larger system in that way. And so, so how do we avoid what we might call parallel worlds? Like we go out into our reflective writing sessions, which are deeply engaging for all of us. And then we go back into the clinic and it's a totally different world where that doesn't exist. How are y'all addressing this in terms of pushing the system itself to transform in narrative directions?
Yeah, great question. And a hard question to answer. Because, system forces are big and challenging at times. I would say, for me personally, at least the microdosing approach, the little notebook approach is sort of my act of resistance against, the EPIC template, in a lot of ways. And my students and residents, I think, see that. I can't say what I would have been as a doctor without narrative medicine because I did the narrative medicine program during med school. But I've had people say to me, both patients and students, that I practice differently than other people that they've been with. And I don't totally know, like, nobody can articulate to me what that is, but I think it is narrative medicine. I think it's a different way of listening to people. And it's a different way of thinking about the story of their illness. So, that chaos narrative, for instance, that I feel like I experience all the time in a Parkinson's disease clinic. Like, I've said that straight out to patients once or twice, where it's felt very chaotic in the moment and they can't articulate what's wrong with them, but something is wrong and it's not always the same. And doctor, I don't know what's happening. And I checked for a UTI and it's not that. So what is it? And I just kind of stopped and I'm like, do you think we might be living in chaos? And it's like this, this light bulb moment for sometimes for the patient, often for their family member who's also sitting in the room and is just bewildered and doesn't know what to do. And then the challenge becomes, okay, now that we've identified it as a chaos narrative, what can we do about it? And sometimes the doing, I had this, one of my mentors in med school would say, don't just do something, stand there. And I think that maybe that's what's different about the way that I practice compared to other people is like just the willingness to let people be who they are, and not over pathologize it and not over instrumentalize it, integrates narrative practice into clinical practice.
We have time for one more question.
You sure?
Oh, me? Okay, thank you for stating your question to me. Mostly I'm into, because I think that one of the questions Dr. Mutter asked and what you've been trying to do is the idea of integrating this into the core of medical education, right? And, we try and do that, but we're really hampered by this idea that everything has to have a learning objective and it has to be knowledge-based and it has to be testable in a multiple choice question, right? So I've been working, as the students here will kind of attest to, I've been working really hard. I love the phrase microdosing because microdosing these other forms of knowledge, these other ways of knowledge, and figuring out ways to not have to test it on a multiple choice question is really, really tricky. So I'm just curious what Duke is requiring you to do that kind of thing. And if you ever think you will get into the quote core curriculum.
Yeah, thanks for the question. We do have to write learning objectives. I write them and then I do what needs done, if you will. We're lucky that we don't have to create multiple choice questions around this material. I think that would be really, really challenging. We do have a little bit of space in the core curriculum in the form of essay questions, actually. So there are a couple of different threads in the preclinical curriculum around, one is on substance use disorder and one is on climate health, where the faculty who are brought in to give those talks are not in the School of Medicine. Actually, they're in the Nicholas School for the Environment or law or public policy, and all of these other spaces. And then the students at the end of that kind of block, instead of a traditional exam, are writing an essay. That's then, it's graded by, law and public policy and so on. But I also get to grade them with an eye towards narrative medicine and like, are you making, if you're arguing a specific point or an op-ed style, like, are you doing it in a way that is getting your story told? And whose story is being left out of the story that you're telling as you're trying to make your point? And so I've been very fortunate in that way. Like I said, we still have to do the Bloom's taxonomy and the whatever learning objectives, but, and I do think that learning objectives have value. I worry sometimes that medical education in general is moving to a much more regimented space. And I think we just have to find whatever opportunities we can to like push back against it. I really like Sam Shem has an article that I think it's 4 or 5 years old now, but it's called Fiction as Resistance. And it's really about how you can use narrative and narrative practice to sort of push back against this hegemony of multiple choice that we all live in.
We'll do one more.
Thank you. I've really enjoyed a lot of what you said. Something that keeps me sane, I'm an M1 for perspective. Something that keeps me sane is having commitments and priorities that are not this job, not this practice, like faith, family, things like that. Have you seen any link between things like that and burnout, moral injury?
Thanks for being here. That's amazing. Yes. It's not something that I'm directly like studying myself, but people have been looking at, what drives you or what brings you into medicine, what keeps you in medicine, and what keeps you going outside of medicine. And I think certainly anecdotally, all of us would say that, you have to have something outside of medicine that keeps you going, whether that's your family or your faith or whatever it is that keeps you human in a way. Because I think, traditionally medical training, and this is shifting, I think, but traditionally things were so focused on, this treadmill of you take the MCAT, you get into med school, you take step 1, you take step 2, you get into resident. And then the funny thing is you get to the other end of that, like you become an attending finally, you've like reached the pinnacle of this career that you've been working towards. And suddenly there's no more roadmap, right? Like, and you get to define what your career is, which is amazing and really fun and really scary sometimes. But I think the thing that keeps you going through all of those little pieces of the treadmill is what helps you at the end of it as well. If that, I'm not sure if I'm answering your question quite, but yes, is the bottom line. Have something outside of medicine that keeps you going. And I think that in itself is just it's a reminder that like you are a full human beyond whatever your role is as a med student or a resident or attending or whatever.
Well, thank you everybody for attending and those of you on Zoom as well. Thank you, Dr. Matri, for this amazing conversation. Just wanted to say real briefly here at the end, next week in Medical Center Hour, we take a break, but then we come back for Brody Medical Education Week at the beginning of November for another really exciting Medical Center Hour. This is on November 6th with Dr. Rebecca Volpe from Penn State School of Medicine. I think continuing some of the conversation that we've had today. She will be speaking to us on what are the humanities and medical education for. So that event will start a little bit later than usual, 12:15. It'll be over in the 3rd floor Claude Moore Auditorium of the School of Medicine. So we hope to see you there and have a great rest of your week.